Hello everyone and welcome to everyone who's joined us today. Welcome to the OzPIPS and IDFA's webinar to acknowledge World Primary Immunodeficiency Week 2025 and to raise important awareness of primary immunodeficiencies. So World Primary Immunodeficiency Week is an annual globally coordinated event to raise awareness for primary immunodeficiencies and to advocate for improved access to diagnosis and treatment for patients to improve their health outcomes. This year's focus is on bringing awareness to the comorbidities of primary immunodeficiency patients suffer from, and we've got speakers that will be talking to this today. And it's important to note for those of you who may not be well versed in primary immunodeficiency that often a lot of these comorbidities are unseen, or you could say that they're invisible. So this week, patients and their families, patient groups, healthcare professionals, policymakers, and the general public unite to bring awareness and understanding of primary immunodeficiency and its associated comorbidities. This particular Awareness Week is observed every year from the 22nd to the 29th of April. So I just introduce myself. I'm Emily Edwards. I'm the Vice President of OzPIPS, and I'm happy now to pass over to Carolyn Dew, CEO of IDFA.
Thank you, Emily, and welcome everyone to our webinar. Before we begin tonight, we would like to acknowledge the Wurundjeri people of the Kulin Nation and the Dharawal people of the lands on which we are presenting from today, and pay respect to their elders past, present and emerging. We extend our respect to any Aboriginal or Torres Strait Islander peoples who are joining us for this webinar. This webinar will be recorded and shared on the IDFA website and sent out as an email with a link to all of our registrants tonight. The Immunodeficiency Foundation Australia is a member-based organisation that represents people with primary and secondary immunodeficiencies. We are a national peak body with more than 2,000 members. Our vision is a future where primary and secondary immunodeficiencies are diagnosed and treated early, with people affected supported by clinicians, community and government to allow optimal quality of life. Our key strategic priorities are care and support through building community, advocacy through driving change, and education and awareness. We hope that you enjoy the webinar and find the information valuable.
So, as I mentioned, I'm the Vice President of OzPIPS, and I'm also a medical researcher in the field of primary immunodeficiencies here in Melbourne. OzPIPS itself is, like IDFA, an Australian patient-led charitable organisation, and our purpose is to advocate and support people with primary immunodeficiencies and their associated chronic illnesses, as well as their families here in Australia. Working in partnership with patients, carers, clinicians, government, and other patient organisations like IDFA, we hope to achieve our vision to enable equitable access to diagnostics and treatments for patients with primary immunodeficiency. Through this, we hope to enable earlier diagnosis and more efficacious treatment, which will improve patients and their carers' quality of life. Tonight, OzPIPS is excited to partner with IDFA for this webinar, and we hope that you find it valuable and insightful.
The webinar invites leading clinicians, allied health professionals and researchers to share information on the comorbidities of primary immunodeficiency. We also have a patient perspective. Today, we will learn about how primary immunodeficiency predisposes to autoimmunity, bronchiectasis, gastrointestinal disease, and some of the research in the disease and therapeutic strategies to help reduce disease burden. We will also hear from IDFA member Lynn, hearing about her life experiences of living with an immunodeficiency and tackling comorbidity. Our speakers are Professor Elissa Denick speaking on autoimmunity, Alex speaking on gastric autoimmune gastritis, and Richard speaking on bronchiectasis. I hope I said that right. We will also present at the end an overview of some of our resources. I'd like to introduce Associate Professor Elissa Denick, who is a co-director of the Precision Immunology Program at the Garvan Institute of Medicine in Sydney. He's an expert on the regulation of immune cell activation and function and how this contributes to the pathology of human immune disease. Alyssa undertook her PhD at the University of Sydney with Phil Hodgkin. She then moved to Toronto, Canada to work at the University of Toronto before returning to her work at the Levin Institute. We now have a short recorded video from Alyssa.
Thank you so much for inviting me to come share with you today about immunodeficiency and autoimmunity. Sorry I couldn't be with you live. So I'm talking to an immunodeficiency audience, so I don't really need to explain to you guys that immunodeficiency happens when our immune system doesn't respond to infections like viruses or bacteria properly, and therefore it can result in severe and chronic infections like pneumonia. But you probably know less about autoimmunity, which is when the immune system also reacts inappropriately, but this time it inappropriately targets parts of our own body. And there are many different types of autoimmune diseases, for example, systemic lupus erythematosus or SLE, autoimmune thyroid diseases, autoimmune cytopenias, which target cells in the blood. But pretty much for any part of the body that you think of, there's probably an autoimmune disease that attacks that part of the body. And often we're tempted to think of immunodeficiency and autoimmunity as opposite ends of the same spectrum. So with immunodeficiency being where our immune system is maybe too weak, and autoimmunity where it's too strong. But we know that it's actually more complex than that. And some of you may actually have experienced for yourself that you have both immunodeficiency and autoimmune diseases. And that's actually true for many patients with immunodeficiency. So if we think about the many different genetic changes that can result in immunodeficiency, probably about 20% of them are also associated with autoimmunity. Or if you've got CVID, you may also have immunodeficiency and autoimmune disease, even if you don't have a genetic diagnosis. So this combination of immunodeficiency and autoimmune disease isn't unusual. It's actually something that happens quite commonly. So how does this operate? Well, we know that making a good immune response against an infection requires many different cells of the immune system, T cells, B cells, macrophages, dendritic cells. But we also know that autoimmune diseases and the generation of that requires many different cell types as well. But today I'm just going to focus on one of my favorite immune cells, and that's the B cell. So the immune system has to recognize lots of different infections and be able to fight it off and clear it. So how does the immune system deal with that? Well, for B cells, it means generating a whole lot of B cells that recognize different things. So B cells have this little antibody receptor on the surface, which is like a detector that detects different things. So each B cell has a different detector that detects a different thing. So now if I get exposed to a virus, say someone with the flu coughs on me, any B cell that detects or recognizes that virus will now be activated. It can proliferate and start secreting antibodies into the serum and into their bodies. So this antibody, which was on the surface acting as a detector, now actually becomes a secreted weapon, which you can then go and bind to the virus and help to clear it. And this is true for infections that we have, but also for vaccinations. But the thing is, because to generate all these different B cells with different detectors is a random process, we also have B cells in our bodies that recognize and detect parts of our own bodies. So now if one of these B cells gets activated and starts proliferating and secreting antibodies into our serum, those antibodies can now travel around our body and cause damage. So for example, in SLE, antibodies might bind DNA where they then can clog up our vessels. In autoimmune thyroid disease, they can bind to the thyroid and either destroy it or turn it on. Or if the antibodies recognize some of our blood cells, then they can destroy those blood cells, which we need to be healthy. So if we have these B cells that can both either recognize foreign things or recognize parts of our bodies, how do we make sure that we only turn on the ones that are fighting infection, not these ones that can cause autoimmune disease? Well, the B cell, I've told you, has this detector on its surface that is specific for something. And in this case, for example, this B cell might recognize this bacteria. But there are lots of other receptors that are also on the B cell that receive signals from different places, like a T cell or from other soluble factors that are produced by the immune system or the body when they recognize bacteria. So you can think of it almost like a smoke alarm. So in your house, the smoke alarm going off might be like this B cell receptor, this detector, detecting bacteria. But then if there's really a fire, you're going to have probably smoke that, you can smell and flames that you might be able to see. And when you have all those different signals, you think, gosh, there's a fire. I've got to, flee and call the fire brigade. And in the same way, the B cell, when it gets these multiple signals, gets activated to go and to produce these antibodies to fight off infection. On the other hand, if you have kind of part of your own body, what immunologists call self, then you'll get that signal. If you have a B cell that detects a bit of yourself, then it'll get that signal through the B cell detector, but there won't be those other signals that an infection might provide. So kind of like if your smoke alarm went off, but you couldn't smell any smoke or see any fire, then you might think, oh, maybe my smoke alarm is just faulty or the battery's getting flat. And so in this case, the B cell doesn't respond and doesn't produce antibodies in an ideal situation. But how does this go wrong to cause immunodeficiency and autoimmunity? And to take you through that, I'm going to use an example of one condition that I've studied for about 10 years now, and that's activated PI3 kinase delta syndrome, or APDS. So individuals with this condition have poor production of protective antibodies, so they don't make good antibodies against some infections to protect them, but they have high rates of autoantibody-mediated disease. So they make antibodies against these self-antigens, against part of their own body. And we wanted to understand why this was. Now, we know that the genes that are changed that cause APDS code for these proteins, which are really important for transmitting that signal from the detectors on the surface into the cell and telling the cell what to do. So is this interfering with how the B cell senses what's around it? And to study that, we took blood from either healthy individuals or people with APDS, or we generated mice using CRISPR gene editing. We created mice that had the same mutation as many of these patients. And then we could look at how the B cells in these people or in these mice responded, either to a vaccination, something that's foreign that you want to respond to, or to self, to our own bodies. And what we found is that when you had a reaction to something foreign, something you want to respond to, having these changed proteins down here mixed up the signals. So now the B cell does go, it does proliferate and does start making antibodies, but rather than making the really protective IgG antibodies, it made IgM antibodies, which aren't as able to fight these bacterial infections that the patients are susceptible to. On the other hand, when you had a B cell with this change that saw self, again, the signals are muddled. And now the B cell, rather than going, oh no, that's not dangerous, I don't need to respond, goes, again, proliferates and starts producing antibodies. So in this way, The mixed up signal within the B cell both contributes to the immunodeficiency and the inability to make good antibodies to certain infections, but also to the B cell making antibodies against self and causing autoimmune disease. Now, that's not the only way you can end up with autoimmune disease. You can get problems with this signaling of the detector on the B cell surface, but you can also get problems with other signals that are coming into the B cell. For example, you can have problems with the T cells that provide help, or other signals from elsewhere in the body. And so depending on kind of what kind of form of immunodeficiency you have, there may be different things that are driving this. And we need to keep studying this to really understand how we can target these things to make them better. Just to finish, I'd like to thank all the patients and families who over the years have helped us with this research and helped us to understand what's going on, as well as our many collaborators and people who have funded this work. Thanks.
Okay. Thank you, Alyssa. Okay, so now we will move on to our next speaker, who is Professor Alex Boussioutas, who's from a tenured academic clinician at the School of Translational Medicine at Monash University in Melbourne. Alex is a Professor Director of Gastroenterology at the Alfred and has also been appointed as Programme Director for Specialty Medicine at Alfred Health. In addition, last year, Alex was appointed as inaugural Director of the Department of Clinical Genomics at the Alfred, and also is head of GI risk management at Peter MacCallum, as well as holding other clinical appointments. In addition, Alex also leads a research program in upper gastrointestinal cancer at Monash and the Alfred, and this research encompasses a number of disciplines, including population health and screening, where he uses novel technologies to aid for early detection of cancer, and also looking into genomics in the investigation of the underlying molecular pathology of gastric cancer. He also heads one of the only multidisciplinary immunocomplications clinics, which oversees treatment of patients with immune checkpoint complications of the gastrointestinal tract, if I speak English. And this is important because it's in collaboration with clinicians from other disciplines, including medical oncology, dietitians, nurses, and other specialist services. He was also the only Australian collaborator of the Cancer Genome Atlas Network in upper GI cancer, which led to landmark studies in the characterization of gastric and esophageal cancer that was published in Nature. Alex is also on the Medical and Scientific Advisory Panel for AusPIPS, and so we welcome him tonight to talk about some of his clinical and research expertise. Thanks, Alex.
Thanks, Emily. I'll just share my screen, if that's okay. And hopefully I've got the right slides for you. Hopefully you can see that and you can hear me okay. I'm getting nods, so I'll persevere. Thank you, Emily, Caroline, and to the organisers of this event, and congratulations on the start of a week in this space. I've been tasked to talk about gastric autoimmunity or autoimmune, and I think you've just heard, those that could hear a lot of it, was we heard about the process of autoimmunity, which was fantastic to actually preempt this talk. But I was really interested in the aspects of autoimmunity or gastric autoimmunity and dysregulation of the immune system that people with particularly combined variable immunodeficiency, CVID, but basically people with inborn errors of immunity, such as this or primary immunodeficiency, and how it might lead to cancer, because that's my area of expertise. And I think this is something that isn't often talked about, because we often talk about the inflammatory and infection complications of these sorts of disorders. But cancer, the risk of cancer is real. So what you see in front of you, I hope, is some of the manifestations of the CVID, or combined variable immunodeficiency. And the important thing is this dysregulation of the immune system. Not only immunodeficiency, but its actual regulation is skewed. And this is what leads to what you heard in the previous talk about more autoimmunity. So this is basically your immune system detecting antigens or components of your own self and then attacking them inadvertently. There's also other aspects of immune dysfunction or immune changes, such as reduced immunoglobulins, which is something Alyssa talked about as well. But there also is this overaction of parts of the immunity as well. And this is what that dysregulation means. And these are the things that cause chronic inflammation. And gastric cancer is almost a prototypical chronic inflammatory condition, and I'll go through it in a couple of other slides. This table that you actually see some of the cancers that have actually been implicated with people that have some form of primary immunodeficiency, and you can see gastric cancer there. There's a more recent paper that I haven't included here that actually says that gastric cancer is probably over and above many of the other cancers in terms of its frequency. So what drives cancer? I mean, one of the things that we have understood after many, many years of research, and you could see citations there from Rudolf Virchow back in 1863, who was one of the first people that actually connected cancer and inflammation actually being a source or a feeder of the cancer that actually developed. As I mentioned before, chronic inflammation is very much implicated in gastric cancer, and the chronic inflammation is usually initiated or induced by an organism called Helicobacter pylori, which has learnt to live in our stomach. One of the fantastic Australians that has actually talked a little bit more about the immune system and cancer is Macfarlane Burnett. And he was head of the WEHI back then in 1957 when he wrote a paper that actually talked about immunosurveillance. And what that means is that you have your immune system that actually can protect against cancer or actually limit the amount of damage a cancer cell can do by destroying itself, by destroying the cancer cells, or by controlling it to some extent. And it's when this control goes off, and this is part of the hallmarks of cancer, if you like, and the areas down the bottom. And I don't know if my pointer you can actually see my pointer, but there's been some landmark studies that were described by Hanahan and Weinberg back in 2000, which was the first one, and then a follow-up study in 2011 that really talked about what are the key features of cancer and carcinogenesis. And you can see there that one of them is unstable immunity or avoiding immune destruction, which is that pink area over there right onto the right. So the immune system is really fundamentally linked to cancer. And what has really brought that to the fore more recently is the fact that we use very strong immunogenic drugs called checkpoint inhibitors that actually rev up, if you like, the immune system to actually fight cancer. So gastric cancer is, like I said, prototypical in that it actually goes in a stepwise progression from normal stomach that is then being infected by the organism Helicobacter pylori. And for some people, but not all people, some people, it actually drives it into a chronic condition called chronic gastritis, or that then results in atrophic gastritis, which is a form of chronic gastritis. This then goes through a stepwise process, and one of the important ones that I'll flag a little bit later, because it basically lives in people for a very long time, is a condition called intestinal metaplasia, and that's a pre-malignant condition. It's not cancer, but it actually can predispose to cancer, if you like. And eventually, with chronic inflammation that continues to drive this from left to right on the screen, as you can see, you eventually get carcinogenesis. Now, one of the things that, again, we've got expertise in Australia is Helicobacter pylori. Now, Helicobacter was known for many, many years. In fact, before it was called Helicobacter, it was thought to be a Campylobacter, which is a type of bug. And we have two people, a gastroenterologist in Barry Marshall and Robin Warren, who's a pathologist, who together back in 2005 got the Nobel Prize for linking Helicobacter pylori, not with gastric cancer, but with gastric ulceration and peptic ulceration. So this revolutionized our thinking of what causes ulcers and damage in the stomach. And then there were subsequent studies looking at Helicobacter and gastric cancer, and it found that it was very much involved in the initiation and then the continual inflammation that we actually saw that predisposed people to gastric cancer. Now, the intestinal metaplasia that I talked about, which is that premalignant condition, tends to happen in people that have autoimmune gastritis. And this is a repercussion of it. This is a result of chronic inflammation that basically changes stomach cells into intestinal cells. And that's what intestinal metaplasia refers to. There are two major types of intestinal metaplasia, and they're you can see them here. It's complete and incomplete. They're somewhat different. And the thought is that the incomplete type has got more risk of progression to carcinogenesis, mainly because it may be genomically more unstable. And these are driven by the immune system, and hence this is why in primary immunodeficiency, we actually see this more often. Now, we think in terms of this progression, and you've seen this sort of diagram many times, if you eradicate Helicobacter pylori, you can actually reverse many things. But we think that intestinal metaplasia, or for some people in intestinal metaplasia, even if you try and eradicate it, for a good proportion of people over here, you don't make it go backwards, it still continues. And that is because that autoimmune process has been triggered and now has been put on automatic. And so people can continue down this pathway. But thankfully, in our community, this is a very low number. So there's been quite a number of studies, and these are what we call meta-analyses that have actually looked at whether there's an association of this progression depending on whether you get rid of Helicobacter or not. And the evidence basically shows that if you've got, and this is shown here, if you've got intestinal metaplasia or dysplasia and you try and get rid of the Helicobacter pylori, people do not regress. They don't go backwards in this diagram. Whereas if you've got chronic atrophic gastritis in the early stages over here, you can actually treat Helicobacter successfully and reduce people's risk of getting gastric cancer, which is very good news for many people if we can get them early enough. So what's the link between combined variable immunodeficiency, or CVID? There certainly is good data that shows that the estimated risk in people here is much, much higher than the general population. Now, thankfully, the general population risk is 0.01% or something. It's really low. And so if you multiply this by 6 times, it's not a huge number, but it's big enough that we can concern ourselves for people that have got autoimmune gastritis. And it's obviously increased in frequency for people that have got atrophic gastritis and intestinal metaplasia. Risk is associated with other risk factors as well. So the risk of progression is associated with having Helicobacter pylori, so getting rid of that is a good idea. Smoking, some alcohol, so things that in lifestyle factors put your risk of any sort of cancer. These are no different. The duration of having CVID or a primary immunodeficiency also counts, because age is an important factor for risk of progression to any sort of cancer, and this is no different with gastric cancer. Now, pernicious anemia, which is a lack of vitamin B12, is a factor of chronic atrophic gastritis because you lose an important hormone that is used to actually absorb vitamin B12 from the body. And because you don't produce this in stomachs that have autoimmune gastritis, you lack vitamin B12, and hence you can actually be susceptible for pernicious anemia. So in CVID, as we've talked about, there's an impairment of mucosal immune function, and this includes both T and B cells. And this dysregulation that causes these autoimmune disorders that result ultimately in chronic inflammation and then this increased susceptibility. And that's the reality for some people that have actually got immunodeficiencies here. So this is a very complex slide, and both sections of the slide say the same thing, basically. They're about almost 10 years apart. I think they're about 8 years apart in terms of the studies, but they are flow charts, and I don't mean to go into detail here, but they're flow charts of people who have got a diagnosis of primary immunodeficiency, particularly CVID in this setting, that basically should go into a clinic that's knowledgeable about this, get assessed for Helicobacter, and you can do this without a gastroscopy just by doing a breath test to see if it's positive, and determining clinically whether there's anything else. Are there reflux symptoms or other symptoms in the upper GI tract that warrant gastroscopy to actually look at whether biopsies are needed to actually screen for these pre-malignant conditions that I was talking about. And then down the bottom, it basically describes the different conditions that we might pick up on gastroscopy, and then the frequency of how we should manage this in terms of surveillance. So for instance, if someone's got an intestinal metaplasia, the recommendation, depending on the degree of metaplasia that's present, whether it's all over the stomach or just in one spot, it could be repeating these procedures every 1 to even 3 every 3 years. And then the more advanced lesions like dysplasia, and obviously you need more surveillance or even therapy if you find an early gastric cancer. And this is no different in the more recent protocols. There's slight differences in some of the years that are there. So my last slide is the take-home messages. CVID patients in particular have higher risk of gastric cancer through this autoimmune process. So if we can detect autoimmunity first, we can survey people and actually decrease the risk of them getting gastric cancer. And even if they do, treat them early by either endoscopy or surgery if required. Helicobacter should be investigated and eradicated, as we've talked about. Screening patients with CVID, given the risk that we've been talking about, is a reasonable thing to do, but the frequency of the gastroscopies really depends on what we find at those procedures. So thank you very much, and I'm happy to sort of address questions whenever people want me to. I'll stop sharing.
Thanks very much, Alex. I think that's very informative. So I think we'll move on now to our next speaker. So our next speaker is Richard Hessian, and Richard is a UK-trained physiotherapist with over 19 years experience in respiratory physiotherapy. He received his initial honours physiotherapy degree from the University of Kiel in the UK in 2001, and then subsequently did his postgrad certification in advanced cardiorespiratory physiotherapy from the University College of London. Richard has in-depth experience in a variety of patient groups, including cystic fibrosis, bronchiectasis, COPD, interstitial lung disease, primary and acquired immunodeficiency disorders, and cardiothoracic surgery. Richard focuses mainly on ICU and acute medicine, where he worked for 9 years in the UK in intensive care, and he developed an extended scope here while he was there in tracheostomy care. Richard then travelled across the world over to Melbourne with his family in 2010, where he worked at Fremantle Hospital in the intensive care and cardiothoracic surgery before moving to Melbourne in 2013, working in acute specialty medicine, emergency medicine and ICU at Maroondah Hospital. Richard now treats and manages respiratory patients privately through Melbourne Chest Physiotherapy Clinic, as well as in the community, where he focuses on improving and maintaining quality of life for respiratory patients in Melbourne. Richard has worked with AusPIPs for the last 5 years on the advisory panel. providing advice, discussion and education about exercise and quality of life for those with primary immunodeficiencies. And he's now starting research. I believe he's undertaking his PhD as we speak, into optimal exercise programs for sufferers of primary immunodeficiency to better inform evidence in order to improve protocols and to give better advice to patients with primary immunodeficiency. Thanks very much, Richard.
Thank you very much, Emily. Can you all hear me? Excellent. We will attempt to share my screen. All right, can I check that everybody can see that presentation, Emily?
Perfect, thank you.
Okay, perfect. So thank you very much, everybody, for inviting me to talk this evening. I'm going to be talking on the impact of a specific comorbidity in immunodeficiency, which is bronchiectasis. It is a difficult one to say, but it is one that I've practiced a lot over the years. Before I get started, I'd also like to echo this acknowledgement of country and just to acknowledge that I'm currently on Gurnai country in Gippsland, and so I'm coming to you and acknowledge the traditional owners of the land. Bronchiectasis is a respiratory disorder which it presents with a large impact on quality of life, and it is a prevalent part of primary immunodeficiency, which is why we are discussing it this evening. Bronchiectasis is an inflammatory disorder. We've heard a lot about inflammation this evening, and it actually starts with an initial infection which causes inflammation. Inflammation is a good thing initially, but unfortunately, in some people, once the inflammation begins, we get some impaired what's called mucociliary clearance, or there's gunk in the lungs, if you will. The impaired mucociliary clearance then leads to obstruction, and we get what's called colonization, where there's lots of phlegm in the lungs, and certain bacteria such as Haemophilus influenza, Pseudomonas, Staph aureus, and other bugs love to live there, and they set up shop, and this causes actual dilatation of the airway. So the airways actually get bigger. And that's where the term bronchiectasis comes from. Bronchi means airway, and ectasis means widening. Unfortunately, then this leads to further inflammation, which then sets up this vicious cycle. So we think, well, that sounds good. We've got airways which are wider, so we can fit more through. That sounds like a good thing. However, when we consider physiologically what's going on, when we are breathing in and out, we have to breathe the same amount of air out that we breathe in, else we're going to blow up like a balloon. And it's a relatively similar time. So therefore, in order to push the air out quicker, our airways actually need to narrow when we breathe out. We can see here, this is just obviously a diagrammatic representation, but when we have the same amount of air or water or anything flowing through a pipe or an airway, when there is a wider diameter, it moves slower. And then when it gets to a much narrower pipe, it moves a lot quicker. I like to think of it like a hose pipe in the garden. One of my children is younger than the others, and he likes to spray the others with the hose pipe. And what I've taught him is that if he covers over the end of the hose pipe, sort of half the end of the hose pipe, it sprays a lot further than if he just turns the tap on harder. And that's the same effect. So when we breathe in, our airways need to dilate, and then when we breathe out, they narrow, and so we can push that phlegm out. And this is a vital part of our airway clearance mechanism. So when we have a wide airway, excuse me, the air moving through the airway, this is obviously a 2D representation, and our airways are 3-dimensional, but essentially the main flow of air, the fastest speed is through the middle of the airway, and then it is much slower on the edges. It's got this called a parabolic look. So when we narrow our airways, not only does it move quicker, but it brings the edges of the airways, where all this phlegm is stuck to the wall of the airways, closer to the air that is flowing quicker, and therefore again moves the phlegm out. So again, actually narrowing the airways is a vital part of good airway clearance. In our airways, so we've got lots of different airways going down into our lungs. It's not just like 2 balloons. It's not just like a bucket. There's lots of different airways. There's actually 23 generations or splits before you get down to the end, and we end up with over 4 million alveoli down at the bottom. So it's a huge network. But at the very top in our throat and in our major airways, we've actually got cartilaginous rings which are holding them open. And that's the area that we clear with a good strong cough. Now, right down at the bottom of our lungs, what's called the respiratory zone is where we have lots of sacs in order to get the oxygen over into the blood. Air doesn't flow at that point. It moves by something called diffusion or pressure. And so at that point, we don't really get any sputum. That's we get different processes. But it's the middle airways, so from called generation 3 down to about 16, where you've got this mechanism where you need to get a narrowing of the airway in order to really push it out. And unfortunately, this is the area where bronchiectasis has its main effects. And so somebody with bronchiectasis may look like they're coughing and clearing lots of phlegm, but all it's doing is coughing and clearing from the top bit. It's not actually getting down to where the main source of the sputum is. And so then that again sets up inflammation, which sets up further damage. And so this then impacts somebody symptomatically. The other effect of widening these airways, this bronchiectasis, airway widening, is that our airway walls are not just one long cell. They are what's called columnar epithelial cells, and so they're essentially blocks. And then when somebody's airway dilates, like in bronchiectasis, those blocks will be essentially spread apart. And so the lovely escalator that moves phlegm up towards the mouth, it now has broken pieces in it, essentially. And so this again contributes to sputum getting stuck. So why are we talking about bronchiectasis in PID? Bronchiectasis, as I said, is an inflammatory-driven disease, and therefore any dysfunctional inflammatory pathways seem to predispose towards to bronchiectasis presentation. PID accounts for up to 17% of patients with bronchiectasis, which is considerable. And it is the most frequent non-infectious respiratory complication of PID, making it so its pathophysiology is unclear and unrelated to the occurrence of previous bacterial pneumonia, where, as we saw at the beginning, those without PID have almost always have a specific pneumonia or hospitalization which kicks this off, whereas those with PID can be much more insipid over time and don't need this specific pneumonia or specific infection. And the improvement in management over time, particularly in immunoglobulin substitution, has allowed us to decrease the prevalence of bacterial pneumonia and mortality, and therefore the impact of bronchiectasis. However, it is still there. I'm going to be talking about health-related quality of life, and I just wanted to be really clear that we're talking about a person's satisfaction or happiness with areas of life that are affected by health or healthcare. We usually measure it through what's called validated questionnaires, which is all those things that you tick at the doctors or online saying, how does it affect me, how satisfied I am, etc. And it's individual to each person. Everybody will be affected differently. And they are often split up into what's called different domains. So although we often think about things as physical, it also takes into account psychological, social, coping, and all areas of our quality of life. Health-related quality of life in PID, we do have to acknowledge effective management of all chronic disease, such as PID, is necessary to improve health-related quality of life. And this is often made worse by delay in any diagnosis. And although it is still, through the work of OSPIPS and IDFA and all of our colleagues on here, diagnosis is coming through quicker and quicker. The delay is still fairly prevalent and considerable around the world. PID shows lower scores in physical functions, self-esteem, and family activities compared to healthy individuals. And you think, well, of course, we're unwell. Of course, that's going to be the case. However, it's a bit more surprising that actually CVID, obviously the most common or the most prevalent form of PID, the health-related quality of life is actually worse than somebody with heart failure or even diabetic patients. And so that is a little bit more confronting. PID in children and self-reported do show that health-related quality of life does start to affect families and children at a very young age. In particular with bronchiectasis, we talk about cough-related quality of life. And this is because of the inflammation, because of all the phlegm, because it's not moving properly. We're coughing all the time. And it's not just a polite little dry cough, it's a wet cough. It's a and especially in just in recent times with COVID, I mean, if you cough in public, if you cough in coals, people move away. No matter how thick your skin is, it does affect how you feel. And all this coughing is so socially unacceptable. Any sort of movement or talking can set off the coughing, and the embarrassment can lead to social isolation and poor quality of life. Essentially, if you thought or if you knew that every time you laughed or talked for more than 5 minutes, you would have a coughing fit, which made people look at you like you need to leave, you wouldn't go out to lunch with your friends, you wouldn't go out to the movies, you wouldn't go out to dinner, you would just isolate yourself. And that is the main issue with cough-related quality of life. The good news is that physiotherapy can help. So airway clearance techniques in particular, which we'll mention in a minute, management of breathing pattern dysfunctions, pulmonary rehabilitation, have been shown to improve cough-related quality of life. It's very individual. It is very much it needs to be a one-on-one with a physiotherapist, but it can absolutely impact the quality of life. And I've been fortunate enough to work with people who have been ready to quit their jobs, or they're clinically depressed because of their social isolation, and got to the point where they've reintegrated into their social circles and kept their jobs. And it's really lovely to see. And it's all about that quality of life. Another issue with the coughing is that we can actually become deconditioned, because as we know, there is a large impact of fatigue with PID, but also if you have this concurrent or comorbid bronchiectasis, you also have this cough. And so we have this increased sputum and muscle weakness, and any movement causes coughing. So therefore you stop moving. if every time you go for a walk you have a coughing fit, you're going to stop walking. And therefore, over time, you decondition, which leads to increased breathlessness and decreased quality of life, which leads to then increased sputum and muscle weakness. And it just keeps going round in a nasty cycle. So what we need to do with some airway clearance is start to get that phlegm moving, and therefore we can move without coughing. We can increase our activity, recondition, decrease breathlessness, and increase quality of life again. And so again, this is a very active thing to do and very, very effective, but individual. When you see a physiotherapist, we should talk. It's again very individual, but we talk through what I call the 5 pillars of bronchiectasis management, where we have medical management, work very closely with our medical colleagues, with respiratory consultants, with immunologists, in order to make sure that everything is as optimized as possible. We also need to manage comorbidities like gastroesophageal reflux and postnasal drip, which will then also make the bronchiectasis worse and trigger the bronchiectasis. So sometimes the answer to a cough is actually some Gaviscon. And so we need to work through those comorbidities as well. Hydration is absolutely key to good lung health with bronchiectasis. And so drinking enough water. The only time we should not be drinking our 1.5 to 2 liters a day is if we've been told not to by the doctors. And that's usually only for heart issues. Essentially, if the body is dehydrated, it's going to take water from all that phlegm to try and rehydrate the cells around, and it leaves very sticky, horrible phlegm behind, which is much harder to move. So drink that water. Regular airway clearance is extremely important. And then what's called a pulmonary rehab model of exercise, which is regular aerobic exercise and some lightweight training. So what is airway clearance? So it is very purposeful. It is efficient clearing of airways where sputum has been collected. You would be doing it up to 3 times a day, every day. It is an ongoing thing, but each session takes about 10 to 15 minutes. It's not painful. It's not arduous. It is somewhat time consuming, but the effects and the benefits are huge. It can take many forms depending on the needs, from breathing exercises through to just walking, deep breathing, coughing, something called a flutter, where you blow into a pipe device and it flutters up and down. But essentially, you need to be taught by a suitably qualified physiotherapist. Not every physiotherapist will be able to provide the advice. All physiotherapists are qualified to, in the sense that it is part of our undergraduate degree. However, that you need to keep up the recency of practice. So what is this? How does this then link back to our health-related quality of life? Let's consider just a very simple timeline here, from waking up in the morning to going to bed at night. If every time you move, you cough, then you're going to be coughing all day. And if you might even be coughing at night, and so you can't sleep. And so at no point during that day are you free from that cough. At no point during that day are you able to walk, talk, laugh, integrate with your friends and family due to that cough, and the cough is controlling you. So by doing this airway clearance in suitable time frames, we can then do a lot in the morning, some in the afternoon, some in the evening, and then we're not coughing at night, and we get these periods where there's no cough. We get these periods where we're able to go out for lunch with our friends. We get these periods where we can go to the movies, where we can go shopping, free of this burden of this cough. And that's a wonderful thing. We can't get rid of the bronchiectasis, but we can regain that quality of life. As far as exercise is concerned, we use something called a pulmonary rehabilitation model of exercise. It needs to be modified somewhat in those with PID due to the fatigue side of things, which again is why you need to be discussing this with a suitably qualified physiotherapist. But essentially, it combines some aerobic exercise, some light walking, about 5 times a week, some very light resistance training, and then posture, spinal mobility is very important as well. So in summary, bronchiectasis is a respiratory disorder. It is very prevalent in those with PID. It is a chronic disease, chronic dysfunction, and it doesn't go away, but we can manage it to the point where it no longer has that impact on the quality of life. Thank you.
Richard, and thank you to Alex for your presentations. They were both very informative and very insightful, and I'm sure very interesting to our members who are here tonight. We're now going to move on to the next stage of our webinar, which is to talk to one of our members to get her insights on immunodeficiency and comorbidities. So I'd like to introduce Lynn Barker, who's going to talk to us tonight. Lynn's been a member of IDFA for over 15 years, and she's actively worked with us during that time as a member of our National Patient Advisory Panel, as a peer mentor in our Circle of Support program, and in an informal mentoring capacity where she engages on a regular basis with many members and many people who suffer from immunodeficiency. Diagnosed in 2000 with combined immunodeficiency, Lynn has received Intragram for about 20 years before recently changing to SCIG. And in Lynn's case, the late diagnosis has led to several comorbidities. As a retired nurse and community midwife, Lynn is currently studying history when she's well. He treasures friendships, education, and support from IDFA, as well as travel and spending time with her children and her grandchildren. So I'll hand you over now to Lynn.
Thanks, Carolyn. I don't actually have slides, so you're going to be looking at my face for tonight. During all of my many years with IDFA, I've met many with primary immune deficiencies and some with secondary immune deficiencies, but I haven't as yet met any that don't have at least one comorbidity, if not several. I have several as well. Carolyn just said I was diagnosed with combined immunodeficiency eventually, but I started on my recognised PID journey 25 years ago. It was a late diagnosis. And I've accumulated many comorbidities over this time, including lung, heart, gut, endocrine, and it goes on. I found they can have a cascading effect upon you. You start off with one and then it affects another part of your body, and then you add in medication, having side effects, and you've inadvertently acquired another diagnosis or two. So my wisest advice to everyone is to do your utmost to prevent collecting any of these additional ones if possible. But we don't always have control over this progression. So from my understanding, what I look at, comorbidities can occur due to your immune deficiency, so an unwanted add-on of the dysfunctioning of your immune system, such as the autoimmune disorders, due to a late diagnosis of your immune deficiency, and hopefully that is going to be on the decline now. The result of frequently occurring infections, and then as a result of the treatments for those infections, so some of the drugs that you need. I'm now brittle, at times severe asthmatic, so I need regular and continual steroids, important for breathing. But I've got a few side effects as a result, including osteoporosis, so I have weak bones that break, and diabetes, which is challenging to manage due to the steroids. But overall, I need to breathe to live and function. I do have bronchiectasis as well, Richard, and I will say here that it's really valuable to see a respiratory physio if you're able to access someone, because I've done so regularly over my journey and learned a lot that has been really valuable. As I said, I've collected far too many comorbidities over these years of living both with diagnosed and undiagnosed primary immune disease, and I've really collected mine all of them as a result of the above. So I've learned lessons from each of these experiences. Infection can quickly get a hold, and it can take significant time to treat, leaving you at times with permanent or lasting damage and impacting every area of your life. I'm someone who suffers with frequent chest infections, often requiring hospitalisation. So I learnt to either have antibiotics on hand or a script that I could quickly access from our local pharmacy. This, along with preventative antibiotics and increases in my then IVIG, moved me from very frequent and lengthy hospitalisations to reducing both frequency and duration of these admissions quite significantly. I also made a few lifestyle changes, such as avoiding places with a high risk of transmission, which included primary schools, so no picking up the grandchildren, shopping centres, and wearing a mask, especially in crowded situations, because sometimes you can't avoid going into crowds. So I was wearing a mask even before COVID. However, in the past 18 months, I managed to ignore a callus on the sole of my foot, and this subsequently became a severe osteomyelitis, an infection in 4 of my foot bones. So that resulted in 5 months of hospital care and ongoing medical treatment. I've still got an open wound needing dressings and packing. I'm on continuous antibiotics and I'm wearing a moon boot long term. In fact, I've already worn out one moon boot. So, however, the expectation was that I wouldn't keep my foot, that I would require an amputation. So I'm very thankful. I'd rather wear a moon boot than lose my foot. So what I saw as a minor infection has rearranged my life and that of my family enormously and almost had disastrous results. So we need to be ever vigilant in recognising and treating or responding to changes in our body or for those with whom we care for. So often our symptoms are not recognisable by the traditional way medical care is focused. For example, a lack of fever does not mean there isn't infection in our bodies, nor in those whom we care for. One of the valuable lessons I've learnt since I joined this PID journey is that we all need to have our own personal advocate. This may be your spouse, but it may be another adult, friend or family who knows you well enough to advocate for you and advocate strongly where required. It may be with you or it may be with medical services. As a parent, they will advocate with enormous strength for their child, and we grown-ups also need a voice who knows the way our bodies behave in illness as well as we do. I've needed my husband to come to hospital often out of hours when I couldn't receive the care we both knew I needed. Unfortunately, that is not uncommon in our experience. So when I'm able, I usually follow through with a chat to admin about what has occurred. I think these experiences need to be converted into learning for staff. If you're able, then reporting any errors that happen to you to a higher authority is just a way of preventing that from occurring to another person, another patient. Our health is complicated, though, by these many comorbidities, and it makes us unusual patients to care for. But there still remains many medical and nursing practitioners who are unfamiliar with immune deficiencies and their impacts these have upon us. So we often need to educate those caring for us, both professionally and in familial relationships. Sometimes this may be verbal or by using written material too. It is vital, if you can, to develop a team of medical and allied health professionals around you whom you're confident in their care and who communicate with one another. Very useful. And make full use of any allied health services you are offered, as their care and education can prevent extra comorbidities and treat those occurring. You may need to research those available in your local community, and word of mouth can sometimes be helpful. I like asking nurses for their opinions because they are often very familiar with the local services and can give you some good recommendations. I've also used community rehab programs with in-home care. I find I needed to avoid collections of people with respiratory disease, and this service was available in my area. So it commenced with a physio at home but included a respiratory care nurse who was really helpful, a pharmacist who reviewed all of my medicines, and then a writing of end-of-life care plan for me with another nurse. Look, I found this all extremely helpful for me, for my current and my future care. However, each state and community has differing services available, and explore them to see what may be suitable or helpful for you in your situation. We are all unique in our manifestation of disease and our capacity to adapt and manage the physical changes that evolve. Even though I've met many people with primary immune deficiencies, I've only ever seen a couple that have been actually quite similar in their health journey to myself. So there's a lot of variations amongst us. Now, also don't forget your mental health support, which Richard did touch on too, as these complex health issues and the challenges they bring with them can put pressure on any one of us. And I found using the mental system through IDFA helps you to chat with someone who's living with the condition, and helps you to adjust to the changes that are occurring. And there's also good mental health support services by your GP too. I've found enormous support from just talking to those who are living with a primary immune deficiency and finding what is helping them so that I can live a life as full as possible, but looking out for the signs that may indicate there is another health concern too. We have a unique set of relationships around us, and we need to be thankful for these people who support us, and include at least one of them in the decisions around our care and future, but always have a backup plan. You need it too, I see. Comorbidities in primary immune disease are really part of our journey. We need to manage them well so that we can that can assist us to living our best life and adapting. Thank you very much.
Thank you, Lynn, for that insightful presentation. I think it's always great to hear from someone with lived experience, and Lynn certainly lives a full life in terms of what she does, in terms of contributing to IDFA, to her family, and to enjoying her own life. So that brings us to the end of our formal presentations for this evening. We've just got a couple of things to do before we wrap up for tonight. So the first thing I'd like to do is to just go to our resource slide, just a couple of resources that are available on the IDFA website, which deal with primary immunodeficiencies and a variety of other conditions that we have talked about here tonight. So feel free to head to our website. You can download all of these resources, or if you prefer, you can actually send us an email and you can order some of these resources. So thanks very much for attending, and I'll now just hand over to Emily for final words for tonight.
Thank you for joining us. We've received a lot of questions for our speakers, so we made the decision not to ask them to them live, but we have spoken to them and we will direct these to them in the coming days for answer, and then they will be put up as frequently answered questions